Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm David Victor. I'm happy to welcome you to the Clinical Viewpoints CME lecture for primary biliary cholangitis, integrating practice-changing updates to improve outcomes amongst patients. Again, I'm David Victor. I'm an associate professor of clinical medicine at Houston Methodist Hospital and an associate professor of clinical medicine at Weill Cornell. You can see my disclosures below. Today, this lecture is focused on the learning objectives you see on the screen here. On completion of this educational activity, we should be able to examine strategies to improve the diagnosis of PBC, evaluate novel evidence on approved and emerging therapies for PBC, differentiate utility of approved and emerging therapies in PBC based on biochemical response, reduction of pruritus and liver-related outcomes, and identify the best practices to integrate recent progress and improvements in outcomes for patients with PBC. These are our program overviews, but to get started, we will start with the overview of PBC and its burden. Primary biliary cholangitis is a chronic autoimmune cholestatic disease with a female predominance. It is mainly diagnosed in women from ages 40 to 70. And data from our FOLD consortium in the U.S. Has shown that the prevalence has increased while the incidence remains the same. This may be due to the aging of our population. In the global PBC, in a systematic review and meta-analysis, it shows that the prevalence is about 14.6 per 100,000 with an incidence of about 1.8 per 100,000 person years. The important thing to note is that untreated PBC can lead to grave complications and liver failure or even death. The impact of PBC is that patients can progress to chronic permanent liver disease and cirrhosis. The average life of patients historically that have been untreated is 9 to 10 years. Also, symptomatic problems associated with the disease can impact quality of life. These include pruritus, abdominal discomfort, jaundice, insomnia, depression, and Sicca syndrome. It requires lifelong treatment and care, and our goals of management are to prevent end-stage complications and to manage our symptoms. The problem with PBC is that it's largely a silent disease up until it reaches permanent problems of cirrhosis. It begins with an immune response in the liver that causes chronic cholestasis and inflammation that can lead to fibrosis after a certain amount of time and eventually lead to cirrhosis and end-stage liver disease. There are multiple risk factors for PBC that come from different aspects. You can have epigenetic modulations that are problematic. You can have genetic influences with autoimmune susceptibility, female or immunogenetic polymorphisms. Also, environmental triggers may contribute as well, including drugs, toxins, smoking, or recent infections. Geographical location also seems to play somewhat of a role. In the natural disease course of PBC, untreated patients have a long protracted clinical course with variable progression amongst individuals. As I said, it's often clinically silent, with patients having only an anti-mitochondrial antibody positive with normal alkaline phosphatase. This occurs in about 0.5% of the population, and this leads us to a delay in diagnosis of ranging from 1 to 19 years, but on average about 6 years. In asymptomatic patients, they do have higher liver-related mortality compared to the general population, with a mean survival of 25 years with treatment and without for symptomatic patients with a survival of 15 years. In the Dutch PBC study, this is highlighted in a number of patients with transplant-free survival in comparison to the Dutch population. As you can see, early PBC has a similar, but not completely the same survival as patients, the Dutch population cohort, whereas patients with moderately advanced, the blue line, have decreased transplant-free survival, and advanced PBC have significant decrease in their survival in comparison to the Dutch population. The burden of PBC is not only in their rates of transplant-free survival. They have symptoms related to the disease that may or may not be improved by medical therapy. They have fatigue, itching, often associated with the disease. We've talked about cirrhosis and its complications. It can have extrahepatic manifestations including metabolic bone disease, changes in their lipids, and an association with other autoimmune conditions. Patients also report joint pains, fatigue, restless leg, and cognitive impairment at times. What is also happening in PBC is that we are decreasing the number of patients transplanted for PBC over time. As you can tell from autoimmune hepatitis and PSC, the rates of transplantation for PBC have been dropping while they are slightly decreased for other autoimmune conditions. It is likely that effective use of ursodiol therapy has contributed to the decrease, but it remains a goal to prevent patients from being transplanted from this disease. So now that we've looked at the PBC and its burden, which is a nice segue into diagnosis of PBC and changes that are now made. It is important to note, as we've previously mentioned, that PBC is delayed in diagnosis often. If you look at the graph on the right, it shows the time between the first abnormal test and the diagnosis of PBC. With an alkaline phosphatase elevation of over 1,000 days until diagnosis, but because of the positivity of AMA, that shows the least days until positivity. So it underscores the need for improved screening in women who are greater than 40 as our target demographic for the highest incidence of PBC with elevated ALK phos on their screening labs. So to begin our first case, this is a 60-year-old Hispanic male who presents for his annual physical. He's had mild fatigue and dry skin over the last year. On exam, he has no remarkable physical findings. His BMI is 27. His laboratory testing was reviewed, revealing an ALT of 75, an AST of 85 with an ALK phos of 320. His bilirubin was 0.5 and a normal serum albumin of 5. In his medical history, he had hypertension, was on an ACE, and he had pre-diabetes. So the question is, does the patient have PBC? At this point, I would say the answer is we're not sure yet. We need more testing. But an unexplained alkaline phosphatase greater than 1.76 or 200 should be explored. But any elevated ALK phos with mild elevation of their AST and ALT should prompt further investigation. So the diagnosis of PBC is required to have 2 to 3 of the criteria explained to the left. An elevated ALK phos greater than 1.5 times the upper limit of normal, presence of an anti-mitochondrial antibody, or a presence of a PBC-specific ANA. Typically, I use SP100 more commonly in my practice, or histologic evidence of non-spurative destructive cholangitis and destruction of interlobular bile ducts. This has been taught to most of us as a florid bile duct lesion, as you can see in the top left panel of histology from the liver biopsy on the right. Given the positivity of AMA in this disease as one of our pathognomonic diseases for autoimmune biomarkers, liver biopsy is rarely needed, but can be helpful when patients are thought to have a classical picture of PBC, but AMA is negative. This occurs in about 5% of the cases. So AMA is our diagnostic hallmark, and it's seen in greater than 90% of patients with PBC. It should be noted that it can be seen in a less than about 1% of our general population, so it is not pathognomonic without the phos elevation. But anyone with an AMA positive should be monitored with serial alkaline phosphatases. It is immunofluorescence of the HEP2 cell, and it is a titer of greater than 1 to 40 is considered positive. ANA in PBC is also positive regularly. So if you see an AMA positive and an ANA positive, this does not mean that they do not have PBC. It is detected in about 50% of the patients. As we spoke, there are greater specific ANAs for PBC. And you can see the percentages here that ANA can be helpful in AMA negative to confirm the diagnosis in patients with ANA specific PBC markers. So back to our case. This is again our 60-year-old man. Further testing was done to elucidate the cause of his alkaline phosphatase. His AMA and ANA specific PBC markers were positive. Fibrosis testing was done to ensure that this disease, though because it is clinically silent, we do not know its initiation in this patient, was done and was actually in the lower range, but not did not show advanced fibrosis. He still had fatigue, and his labs are repeated here. So at this point, we can confirm this patient has PBC. So what should we do for this patient now? Should we watch and wait and see if this improves on its own? Should we risk stratify the patient before deciding on treatment? Or should we treat immediately without further evaluation? At this point, we should treat immediately without further evaluation, given that the patient does not have clinically significant cirrhosis or symptoms of liver failure. He should be initiated on therapy at this point. We need to talk about risk stratification because it was done for this patient, but is not commonly done in PBC in the past. But now, given our ability to accomplish transient elastography, fibrosis testing should be done at the time of diagnosis and in serial surveillance for people with PBC. You can get a baseline using non-invasive testing, and it also will highlight the patients at greatest risk for complications for those with advancing fibrosis. And using our GLOBE PBC score in the box to the right, after 1 year of ursodiol therapy, bilirubins and normal ALP are now thought to have important prognostic implications after 1 year of therapy. It also showed that advanced fibrosis with an MRE score of 4.3 or greater, or a kilopascal of greater than 10 on transient elastography, also predicts the advancing patients toward poor outcomes and hepatic decompensation. In treatment-naive patients, there are ways to risk stratify. Patients that are male, less than 45 with a diagnosis, have higher rates of progression, as do patients with advanced fibrosis. Patients with ANA-specific PBC antibodies are higher risk to progress, and higher risks of fibrosis at initiation of therapy also speak to a disease that is more likely to progress to decompensation or significant liver disease. There are a few special cases of PBC to mention. In AMA negative patients, you will consider biopsy in patients with clinical therapy or who have an ANA positive without specific PBC markers. And there is a premature ductopenic variant that happens in about 5 to 10% of patients who have significant cholestasis and rapid progression towards cirrhosis. We do always have to mention overlap, though this is outside the scope of a PBC talk. It is a diagnosis that combines the diagnosis of autoimmune and PBC, but must have two of the following: an ALK phos consistent with diagnosis of PBC, a positive AMA, or bile injury consistent with PBC in some part of the biopsy, and elevated ALK phos greater than 5 times the upper limit of normal with an increased IgG with moderate to severe interface hepatitis on biopsy. So now that we've talked about the diagnosis of PBC and the requirements of serologic and laboratory findings or biopsy confirming PBC, we need now to move our attention to approaches to initial therapy. So this is a nice algorithm that we're going to spend a little bit of time on walking through. So a patient who is diagnosed with PBC should have staging, as we talked about, for risk stratification with MR elastography or transient elastography, which we call FibroScan in most cases. Patients who do not have decompensated disease or who can tolerate it should all be considered for ursodiol therapy. Ursodiol should be dosed in patients with PBC at 13 to 15 milligrams per kilograms per day in divided doses. Typically, I calculate their dose each time I meet the patient to ensure that they are adequately dosed. Patients at times can be ursodiol intolerant, typically due to GI side effects or diarrhea. For patients with that problem, they move to the end of the therapy, which we will discuss later. In patients who are able to tolerate ursodiol, you can look for response to their ursodiol therapy. Now, this response is not done at 1, 2, or even 5 months. The earliest you can really assess for effectiveness of ursodiol is at 6 months. If at 6 months, their outphos remains greater than 1.9 times the upper limit of normal, or the bilirubin is greater than 1 time the upper limit of normal, you want to consider, have they progressed to cirrhosis first? But you also want to consider these patients that they've had an inadequate response to ursodiol therapy. It's possible, however, for patients to be under these parameters at 6 months, and they should continue ursodiol for another 6 months. And if they have not had improvement in their alkaline phosphatase to less than 1.5 times the upper limit of normal, and their bilirubin remains greater than 1 times the upper limit of normal, or greater than 0.6 in some of the literature you read, and they have not decompensated, these are patients you should consider to add second agents on. So as you walk down, you start urso. If their response is marginal at 6 months, you consider second line, unless they are decompensated. And if they have not had a complete response at 12 months, you consider second line therapy. For patients with decompensation, as you can see, we should consider transplant referral. In those patients, they may also benefit from further therapies, but we should not initiate therapy alone in patients who have decompensated. So other considerations in therapy for patients is that despite our focus on alkaline phosphatase and transplant-free survival, patients have to live with this disease forever. So there are things you must consider in patients being treated for PBC: pruritus, fatigue, dry eyes. You have to worry about their bone health and make sure there are no other autoimmune diseases. So back to our patient. This is, again, our 60-year-old Hispanic man who's been diagnosed now with PBC and initiated on ursodiol at 13 to 15 milligrams per kilogram per day in divided doses for 3 months. His laboratory testing shows an improvement in his outphos, down from 320 to 250 after 3 months. His AST and ALT have mildly improved as well. His bilirubin remains less than 0.6 with a normal albumin. FibroScan done at time of diagnosis, again, did not show advanced fibrosis, and he still has mild fatigue. So ursodiol and PBC as therapy, again, shows from our global PBC disease that patients treated with ursodiol have a decrease in transplant-free survival. So having a higher line here shows that they are less likely to be transplanted if they have treatment with PBC. It reduces mortality and improves transplant-free survival. Even though on ursodiol, it is possible that patients can progress to cirrhosis if they do not have complete response. Now, this is a study from the global PBC data that talks about combination of two biomarkers, our alkaline phosphatase and bilirubin, to better predict transplant-free survival. As you can see, the patients with an ALK phos less than 2 times the upper limit of normal had a 15-year transplant-free survival of 73%. A patient with a total bilirubin less than 1 had a 15-year survival of 74%. But if you look in patients who had both parameters together, they had an increased survival. But if you look at patients who did not have these parameters and had greater than 2 times the upper limit of normal ALK phos and a bilirubin greater than 1, they had a significant decrease in 15-year survival. This is shown at 5 and 10 years as well. So it shows that adding bilirubins, which typically I use 0.6 or higher, but in this case, 1 times the upper limit of normal, can help to stratify risk for patients who may benefit from further therapy or are showing progression of disease. And this brings us to this concept of deep response to therapy. If you look at transplant-free survival from the target PBC group, it shows that patients with deep survival or deep response, meaning improved, if not normalization of alkaline phosphatase, versus patients who had an adequate or less than 1.76 times the upper limit of normal, that patients who had improved response to their alkaline phosphatase did better than those who had what we used to consider an adequate response. So back to our patient. Does he qualify for additional therapy at this point? We have seen in 3 months, again, an improvement in his alkaline phosphatase. So does he qualify for therapy at this point? The answer is no. He has not been on URSO long enough to define if he has had an adequate response to therapy. So now we want to move on to what is second-line therapy after we've talked about the initiation of therapy, which again is ursodiol, 13 to 15 milligrams per kilogram in divided doses per day for at least 6 months. So this is a new case. We've finished with our first patient and moved on to a 65-year-old white female who presents with a moderate response to ursodiol. She's been on ursodeoxycholic acid for the last 2.5 years. Her elevated ALK phos has persisted, but worsening pruritus over the last 6 months has developed. Her current laboratories show an ALK phos of 2.3 times, an ALK phos of 232, but a total bilirubin that's less than 0.6 at 0.4. She has a transient elastography done now that shows mild fibrosis in the F2 range on transient elastography of 8.2. She was diagnosed with PBC greater than 5 years ago. Her ALK phos at that time was 500, and as you can see, has improved to 232, but has not had a complete response by any definition. She was AMA positive, and she is now developing pruritus, as we stated. Fibrosis assessment along the way has not largely changed, but is not normal. So here, as we look at inadequate response or complete response to ursodiol, based on the global PBC data, that in patients that are not treated, they do the worst with transplant-free survival. Patients with incomplete response have a moderate improved transplant-free survival, but in comparison to complete response, which is not the same as deep response, but complete response being 1.76 times the upper limit of normal, that they have the best response. So there is benefit to ursodiol, even if it doesn't completely improve you, but it is important to know that there is benefit even in those that are treated without complete response. It is also important in my clinic to talk to patients about ursodiol compliance. Taking a pill twice a day, every day, for your whole life can become monotonous and easy to forget. You also want to confirm dosage. Weight changes, whether up and down, can change whether they are on the correct dosing for the medicine. And you want to check for other medicines they may be taking that can impair the benefits of URSA, which especially in patients with itching can be bile acid sequestrants. So in looking at the UK PBC cohort and disease activity and URSA response, I think the most important part here is that they did deeper analysis with proteomics to show that significantly higher rates of disease markers in URSA patients that were non-responders. They showed higher response in patients with abnormal liver enzymes and no difference in those with normal ALTs stratified by bilirubin. This shows that even as we look for deeper markers of inflammation, that there is evidence of ongoing inflammation in any patient who has elevated alkaline phosphatase levels that are not associated with a complete response. So there are patients who look good in our criteria, but continue to have inflammation and damage to their liver over time. So what are our options when we consider PBC therapy in patients over time? Well, there are currently 3 FDA-approved second-line agents for patients with PBC. There's obeticholic acid, which we have made OCA here just for ease, which is a farnesoid X receptor agonist. There's aripiprazole, which is a PPAR agonist, seladelpar, another PPAR agonist, and there are other that have been used, which are fibrates, which are PPAR agonists as well, but are approved as FDA-approved lipid-lowering agents, not for PBC at this point. So in speaking about obeticholic acid, this has been on the market with an accelerated approval by the FDA for some time. It is indicated for patients with ursodiol or who have been on ursodiol but have had an incomplete or inadequate response or who are intolerant to URSA. It is important to note that there is an FDA black box warning for this drug. This drug should not be used in patients with hepatic decompensation and failure. It has resulted in fatal events in patients who were treated who had hepatic decompensation and required liver transplant and others. It is contraindicated for patients who have had decompensation or who are actively decompensated or who have evidence of significant portal hypertension. Permanent discontinuation of OCA in patients who develop cirrhosis or decompensation should be done and monitoring for adverse events is required. While there is a significant black box warning, this is the data to suggest why it was approved conditionally by the FDA. This is the POISE trial. As you can see, there were 3 arms with a 5-year open label extension. The primary endpoint at 12 months was achieved in patients who had a reduction in their alkaline phosphatase, a bilirubin of normal, and an improvement in their alkaline phosphatase. And as you can see, there was significant improvement in the patients on obeticholic acid in comparison to placebo. In the safety concerns, there was itching that was much more common in those that took the drug versus those that were on placebo. But as you can tell, pruritus was significant in those on placebo as well, with 40% versus 56 and 68%. The current dosing recommendations is titration from 5 to 10. But as you can see, serious adverse events are more likely in the 10 milligram initiation arm. What is important to note is that OCA long-term had durable effects out to 6 years. In comparison to the global PBC data, it showed that patients who were treated with obeticholic acid for this time had decreased risk of death and had improved transplant-free survival. So that is something to note, that the durability of response has improved the response for these patients over a 6-year time frame. Other agents to consider that have recently been approved is elafibranor, PPAR agonist. It is indicated in combination with URSO in patients with inadequate response to URSO or in patients intolerant to URSO. The common adverse events had some weight gain, diarrhea, abdominal pain, mild muscle injury, and some concerns for bone with some fractures noted. In their Elevate trial, which were elafibranor patients, there were 80 patients in the elafibranor 80 arm versus placebo with a primary endpoint at 52 weeks. And you can see in the baseline characteristics, significant number of patients in this trial had advanced fibrosis or even cirrhosis. And the results were fairly impressive, with patients achieving the primary endpoint in 51% of the time, which showed improvement in their alkaline phosphatase and normal bilirubin. Their itch scores did not significantly change in the two groups, and there was no significant safety symbol. However, there were elevations of creatinine kinase and some muscle injury that did occur in the elafibranor group at a higher rate and must be monitored in these patients. If you look at the subgroup analysis, this shows that the higher the level of alkaline phosphatase, the lower the biochemical response was in patients on elafibranor. But it's significantly higher than the patients who were on placebo. And you can see dramatic improvement in patients who had 2 to 2.5 and less than 2 times the upper limit of normal in the elafibranor group. This is also seen in the alk phos normalization in patients less than 2 times the upper limit of normal. And as we move toward deep response, this may be an important thing to consider in these patients. They also did an open label extension out to 156 weeks at this point for patients who were on placebo were allowed to cross over and begin elafibranor after the trial. And as you can see, a significant portion of the crossover patients achieved biochemical response this continued to be durable out through these weeks. It is also important to note that continuous elafibranor, as you move farther out, where there is no data on our crossover at this point, there was improvement in biochemical response over time. This was seen as well that continued therapy over time increased the number of patients who were able to achieve alk phos normalization. Elafibranor also showed that there was no progression of bilirubin, which we've talked about as a biomarker, and liver stiffness and ELF scores, which is a blood-based fibrosis test, showed a tend towards stability in patients who were receiving it, which is important and given that there were patients with advanced fibrosis. There was a change in measures of pruritus that suggested some improvement in those who crossed over from placebo to elafibranor, and they were similar to those improvements seen in those receiving continuous elafibranor. There was an improvement in fatigue in patients who had moderate to severe fatigue and sleepiness in some of the patients who had treatment with elafibranor. You saw that this fatigue improved over time, and it may be that there is improvement in these parameters for patients who have significant fatigue with the treatment of elafibranor. Moving on next to seladelpar, also a PPAR agonist and recently approved in combination with URSO, who have an inadequate response to ursodiol as monotherapy. It had higher rates of complications, including headache, abdominal pain, and nausea. In their response trial, Sela at 10 milligrams versus placebo, you see that there were patients who had liver stiffness that were advanced to some degree, with 14% of patients having cirrhosis. Most patients had the disease for quite some time that entered the study. And you can see that seladelpar at 12 months had biochemical improvement with an alk phos reduction of 42% versus 4% at 12 months. The reductions were early and sustained. Bilirubin was the same, and there was a significant decrease in pruritus in patients with moderate to severe pruritus on the CELA group versus placebo. There was no change in real adverse events between the two groups. And as you can see, the outfos normalization was seen in 25% of the patients treated with CELA. This is again to highlight the improvement in pruritus in the patients with a greater than 3-point decline occurring in about half of the patients on the seladelpar group, as well as 31% having a greater than 4%. There was no emergent pruritus with seladelpar at month 12, and again, complications were similar between the two groups. This is an ongoing use as an open label phase 3 study of 10 milligrams of seladelpar with a rollover similar to the elafibranor data. And they are continuing to watch these patients through this time. They will follow these patients to see if continued biological improvement and outfos normalization grows over time. And as you can see, as the months grow out to 30 months, there were patients who achieved a biochemical response, outfos normalization, and ALT improvement that was durable over time. It showed a reduction in itch through 6 months with seladelpar, and no new adverse events were noted. The muscle, renal, and liver-adjusted events remained stable over 3 years of seladelpar use. I'm going to mention fibrates here. They are PPAR agonists, and some of the real-world data we have for combination triple therapy that is out there. To highlight, fenofibrate and other fibrates are not FDA approved for PBC. We worry about rhabdo, some hepatic toxicity or decreased renal function, and the use is discouraged in decompensated patients, which I would not use these outside of a transplant setting as encouraged by ASLD. These are the two trials that people have really looked at, both based on benzofibrate. Benzofibrate is not approved in the US, but the BEZ-URSO trial was done and showed a complete biochemical response in 31 versus 0 patients with a normal outfos in 67 versus 2. And there was some improvement in itch score in these patients. This was again shown in a Japanese cohort. So there is benefit to fibrates that are out there, though the data is on a fibrate not approved in the US. This is the fibrate OCA study. It is a PBC in practice. It is a retrospective cohort study of 1,800 patients. It identified patients initiating second-line therapy or obeticholic acid. The median time to starting OCA was longer than fibrates. The change to second line of care therapy often occurred during follow-up. Fibrates were added to OCA in 96 of these patients, whereas OCA was added to fibrates in only 22 patients. Most patients were Child's A on therapy. As you can see to the right, there are characteristics. So there is some experience with triple therapy, though there is no good data at this point. But in patients without a deep response, you may need to consider some of this data moving forward. So now that we are really moving toward the end of our talk, and we're going to talk about our purpose for being here. In the past, we have kind of been on the wait to fail that give patients URSO and hope that they continue on their transplant-free survival. But if they have a partial response or inadequate response, we just have nothing much else to do other than watch and make sure their fibrosis doesn't progress. Whereas now we are trying to consider personalized therapy based on extrahepatic manifestations, including itch, fatigue, trying to initiate more therapy for these patients to induce a deeper response so that the patient can have better quality of life and decreased transplant-free survival. So our last case, this is a 45-year-old Black female who presents with complaints of long-term fatigue and pruritus. She has been on ursodiol and OCA for 6 months. She was added her OCA 2 years after urso. Her current labs show the ALK phos of 350 with a normal total bilirubin and moderate fibrosis on her FibroScan. You can see her diagnosis here to the right. So at this point, she is on second-line therapy, and we need to consider what is her response and where do we go from here. So this is where we talk about our unmet needs in patients who are on second-line therapy who have not had a complete response. We don't have clear guidance on this, but it may be that adding third agent is where we're moving toward in the future, but not currently. And it leads us to the potential future agents. We have PPAR agonists that are continuing to be used, and we will talk briefly about our ileal bile acids transporter inhibitors. This is the VANTAGE studies with viloxabat on cholestatic pruritus in patients with PBC. You can see this is a very small study, but patients had significant itch and were given 20 milligrams, 80 milligrams, or placebo. You can see that there was a significant improvement in the change in serum bile acids in these patients with improvement in their serum bile acid responders. There was some safety data on viloxabat that's concerning with diarrhea, but no clinically significant change in bilirubin, AST, ALK phos, or ALK, and it was selected as a 20 milligram dose going forward. Patients did say their quality of life was improved. So these IBAT inhibitors may be something we move forward towards in patients who have clinically significant pruritus that negatively impacts their quality of life. In conclusion, PBC is a rare disease that is a chronic cholestatic liver disease that is important to diagnose as early as possible. Patients with cholestatic or elevated ALK phos should be screened and evaluated if they have risk factors for PBC, and patients with AMA positive should have their ALK phos followed normally. Patients with advanced liver disease should be treated like cirrhotics and screened for HCC and esophageal varices. And we want to prevent cirrhosis at all costs. While ursodiol remains the first-line therapy for PBC, second-line therapy should be encouraged. We should move toward the concept of deep response to alkaline phosphatase moving forward, and a knowledge and importance of the multiple second-line agents with their risks, benefits, and improvements to both liver-related and extrahepatic manifestations should be considered in each patient who does not receive a complete response to alkaline phosphatase with urso alone. Thank you all very much. Here is how you get your credits. Please follow up on the Practice Point website, and here's how you download the Practice Point website for your mobile app. Thank you all very much.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practicepointcme.com to complete the post-test and evaluation to receive continuing education credit.